Good evening, everyone. Respected Dr. Dhruvi Shah ma'am, esteemed members of IADPE, and all our dear doctors. A warm welcome to each and every one of you to yet another inspiring episode of the Learn from Our Master series organized by International Association for Dental Practice Excellence. Crossing 100 webinars is definitely an amazing ride so far, and I thank all the doctors who are attending our webinars and like our Instagram and Facebook pages, and we are very humbled to see your positive feedbacks. For those who are attending our webinars for the first time today, we will just give a brief introduction. We are the International Association for Dental Practice Excellence, a dental platform in which we believe quality education always ensure predictable outcomes of dentists of all disciplines and abilities. Our organization is established based on the fact that dentistry is complex and requires ongoing learning experiences. We conduct various webinars and workshops to enhance the skills of dental professional and guide their dental journey. Today's session is especially exciting as we explore one of the most innovative advancements in modern endodontics, guided endodontics, precision, predictability, better outcomes. To guide us through this fascinating topic, we are privileged to have Dr. Dhruvi Shah, MDS, with us. Dr. Dhruvi Shah is an oral and maxillofacial radiologist and currently serves as senior lecturer at Karnataka School of Dentistry, Ahmedabad. She is certified in digital implant planning, surgical guide designing, and 3D model fabrication. With extensive expertise in advanced CBCT interpretation and comprehensive 3D radiology reporting. She has been associated with several radiology centers across Ahmedabad, Mumbai, Pune, and Chhattisgarh. Her experience in digital dentistry and radiology makes her an ideal speaker for today's topic. We are truly honored to have you with us, ma'am. Without taking much of your valuable time, I now invite Dr. Dhruvi, ma'am, to begin today's session. Over to you, ma'am. Welcome.
Hi everybody. As Dr. Juna said, I'm Dr. Dhruvi Shah and welcome you all in this session. So let's start diving deep into the uh, as today's seminar. I hope I am audible to you all, and I hope my screen is also visible.
Yes, doctor.
So, okay, done. Okay. So, you can ask me questions via, this. I will give you a transition time where we can discuss question answers, or if you have any doubt, do let me know in the through the comments or at the end of the session. Okay. So, today's topic is a very, advanced topic, you can say a very new age topic for us everybody, and I hope I'm more thrilled today because probably you guys are doing more RCTs routinely than I have done in my lifetime, and always I get to see your RCTs post up through CVCTs, but today is one of the opportunity where I can tell you, or I will be able to teach you like what to do before and during the procedures. So I'm humbled as of now to teach you this RCTs, through a guided perspective. Okay, so now routinely, now I want to ask you questions. So routinely, you all are doing an RCT. Okay, so how much time does it take routinely for you to complete one RCT, a normal, very good access opening RCT? Can you tell me in the comments, like, what is the minimal time? Is it 20 minutes, 30 minutes? What's the max time? Do you yeah, I think 30 to 45 minutes some are writing. Okay. So yeah, the easiest, I guess, anteriors can be, I guess, 15-20 minutes. Posteriors can be, yeah, 1 hour single visit. Oh, wow. 45 to 60 minutes for posteriors. Perfect. Now tell me, no, in the upper, where you think that there is a lost MB2 or you are finding a like a dentinal map of MB2 now, or there's a grossly carious tooth, or you can say an anterior post-trauma tooth which has come to you. Now tell me, in such cases, what is your ideal time? Like, what is the time? Now tell me, if such case is there, then how much time is do you like do you take for those cases where you have to find the canal where it's very calcified, where I guess you are fishing MB2 and all. So tell me, oh, 1 hour 30 minutes for calcified takes time. Oh yes, diulcerated cases take time. Yeah, 40 minutes. And I bet during that time your neck and I guess your kamar, if you can say, spine has given your I've lost all hopes. Yeah, 1 hour 45 minutes with loops and magnifications. So I guess till that time your I guess neck and your back has sprained. You are done. The patient's mouth has also given uh, have lost its hope, and sometimes because of this excessive time of mouth opening, there are cases that post pay patient will complain that I am having a severe pain anterior, like I cannot open my mouth now. I think I this might be one of the routine not routine but in a week cases like this. I hope you are all finding such cases. So this is where transition comes. This is where guided endodontics takes place to help you to minimize your time. This 1 hour, 40 minutes where you're fed up. Now you are telling that a bus next time, you come next time. Now then over the next time, same grill happens. You have to find it. You're putting lots of chemical inside, EDTA or decalcifying all medicines and obturating materials and all, because you have to get that EDTA and everything. So this is where wasting your time, energy, your materials. Sometimes even the patient gets cranky. Sometimes it loses hope that this doctor does not know anything. Who takes so much time? Who takes so much time? Who is giving me a lot of pain? So everything. No, already you are going to this type of case is going to take multiple 2 to 3 visits. So this is where guided endodontics is coming as a boon to endodontics, conservative and endodontic practice. So yes, let's dive deep and hope, and I hope that this through this seminar and through this lecture, you will have the more confidence to take up those cases with minimal time, minimal conservation, perhaps, and very successful RCT outcomes. Okay, so starting with today's lecture. So, as I said, the problem statement. So, which are those cases where we are finding or we are losing hope? They are, missed canals. It can be a missed canal. It can be a calcified canal where you can see iatrogenic perforation or a ledge form. It's very usually very common in lower anteriors where there's a bifurcation, where there's a trifurcations. Lower anteriors, most common bifurcations are there, and I've seen so many post-op like RCTs, pre-RCTs, CBCTs, where a ledge is formed, where there is a perfo, and the excessive dentine has been removed because you're fishing it. You have to find those canals. So yes, long chair side times as we have discussed. So all these cases which have led us to this foundation. So why guided endodontics now? Now, where it all started, you have probably heard about guided implantology. So this all started in medical field. They used this in neuroscience and neurosurgeries to locate the tumors. So you have probably heard guided bone biopsies or guided neurosurgeries. From them, the concept was taken and had come into implantology, where successful implants are now placed all on fours, all on six, zygomas, PSIs, even pterygoids. All now cases are very very successful through guided implantology, where time has been within few half an hour you are placing all fours, all tens, basals, and pterygoids. without opening a flap, without even, dropping a single pint or single drop of blood. So now, because of the success, this came into endodontics also, that like, why not take the advantage, why not take the principles of that guided implantology and use that to reduce this thing in endodontics. So from there the concept had arrived. So what are the advantages? As it's written, that conservative access, you will have a guided location of your nerve, so your canal, guided approach, that exactly this is the point where you have to drill it. So yeah, guided approach gives you conservative access, precise birth trajectory. Hydrogenic errors, as I said, ledge formations and all, can be easily reduced through this. And of course, improves predictability. Either fishing out your MB2, we can give you the direct access point, that over here, between a little bit, is it medially or through the line of mesiobuccal, you will find your mesio MB2 canal. Okay, so all those things. Okay, now what is now guided endodontics in a very theoretical language, I want to say it. So guided, it's a digitally planned, a template assisted technique that facilitates accurate access cavity preparation using CBCT and CAD/CAM generated guides. I hope you all know CAD/CAM is that computer assisted and machines and designs. Okay, so they are digital plant. A template is used in this, where accurate access or cavity preparation is done using two very important aspects: CBCT and intraoral scans. So, guided endodontics in general have a two types, you can say. It's one is static and one is the dynamic. So, core principle, as of now, you know what is the principle. It is prosthetically driven. It's minimally invasive preservation of pericervical dentine. As you can see over here, this is the point. This is this point where you will point, or you will drill with your burr. So, guided linear drilling and everything is all precise and up to the mark. Okay. So now what is the types, as we discussed? What is the types? What is static and what is dynamic? Okay. So as the name suggests, static means that a template is given where through the help of a template or a 3D printed guide, you will access the cavity. And dynamic is real time. One of the very common example in medicine is USG, real time, will give you real time acquaintance or knowledge of your drilling path, is dynamic navigation. Okay, so that's the basic workflow. The basic, difference between static and dynamic, that the static is, it's already all the statistics are pre-decided, and dynamic is that you can predict your outcome during the time in a real time manner. Okay, so that's the basic difference. 3D printed and real time tracking. Navigation is a pre-planned, and you can adjust also during your procedure in dynamic. So cost is now this. Why the huge difference is the cost. Stat will come later into the seminar, that why and how. So static is cost effective and dynamic is not little. It's a very expensive setup, you can say. But static is high accuracy, and we'll discuss that also why. And dynamic is why technique sensitive. Availability widely available, and dynamic is limited availability because, as I said, it's expensive. Not everybody can afford to have that setup. And it's a little bit technique sensitive. So yeah, you need to also invest in your no practical knowledge also. You have to be thorough with it also to use it. So not everybody can use this. So yeah, that's how it is a little bit limited available compared to what static are. Okay. So again, is no before starting before starting this everything, like, we have to also take into considerations about its pros and cons. Everything has its pros and cons. So this is guided endodontic is still into the research. Still, it has lots of, you can say, its limitations. And that is where the seminar can help you, that you have a huge ocean where you can take this seminar. you can practice it, and you have the hope to make it better, to use these templates and make it more accessible, more better. So as I said, certain limit. Let's start with indications. So, as I said, pulp canal obliteration, or you can say calcific metamorphosis or calcified canals. So, in the cases of pulp canal obliteration, as I said, calcified anterior teeth, then invaginatus case, where the tooth within a tooth concept, where you have no idea that where the actual pulp is or whose pulp it is. Is it the pulp of the original tooth, or there's a pulp of the tooth which is within inside? Fiber post removal. That's also one of the trickiest cases where chances of fracture are very high. So yeah, fiber post removal cases, retreatment cases, and guided microsurgery. Again, the name is conservative and endodontic, so you have to conserve also. So nowadays, uh, radicular cyst or a huge, you can say huge radicular cyst are salvageable. In the earlier times where the tooth might be extracted or have to extracted, we have now opportunity that we can salvage the tooth by going for apexectomy, but guided apexectomies. Yes. So yes, we can salvage the tooth through guided macrosurgeries also. Contraindications, you will only tell me after the end of this seminar. So we'll come back for this. Okay. So, starting with dynamic navigations, first part in the guided endodontics. So, what is basically a dynamic navigation? So, basically, it is a, as you can say, you are driving a car and you are using Google Maps. I hope everybody, nowadays is a very common to use Google Maps for your location. So, similarly, as the Google Maps tell you the path that where you have to go in a real time manner, and it also warns you when you are distracted from the path. So basically, instead of taking a left, if you have gone straight, it will automatically alarm you that no, you have to take a turn, or you have to again take a U-turn for taking the right turn. So this is the where there's a real-time navigation, and you are the driver who's following the path. Similarly, dynamic navigation tells you that exactly where you have to drill in the real time, what is your path to drill, and it will alarm you, through the sensor that you are deflecting from your path of access, you're deflecting, and it will automatically or instantly warns you, so that not even your pinch, 1 mm or 2 mm of your denting can be lost. So this is the one of the most advantage, high advantage of this. It's in a true sense is a conservative approach. So real, as I said, the key features are real time drilling, live positional feedback that, as I said, will give alarm you if you're going to deflect from your path. No physical guides are required. No, you don't have to make a template, 3D printing templates and all. And enhance flexibility in excess preparation. So if you want to change the path, after starting your preparation, you feel no, it's a little bit palatal or it's a little bit lingual. You can in real time can change your path also. So yeah, all those things. Now how it works. So it's basically, you can say, as you can see over here, it's a triangle of sensors, a good CBCT planning, and a good software. So this is a triangle where all dots are connected. That's the CBCT, the sensors, and the softwares. We'll see how. So basically, first and foremost is the use of CBCT. So all guided endodontics core component starts with CBCT. You have to have CBCT in all those cases. Okay, so starting with CBCT acquisition of the teeth in question, then a fiducial markers, as you can see over here, fiducial markers are, have to point those markers. You have to, for example, if we are talking about upper molar, upper right molar, then we have to place our markers telling the softwares that this is the patient. So we have to place one marker on the patient. Then we have to, then other marker we have to place on the tooth, that is the upper right molar, the tooth in question, we have to place a marker over there. So this type of markers are placed so that the software can recognize that yes, this is the patient and this is the tooth in question, and it's the same CBCT of the patient which we are linking. Similarly, what you do in your car, you have to have your Google Maps on your screen. You have to connect your phone with the, be it Android or be it Apple, you have to connect via Bluetooth to your car so that they can both be in sync. Similarly, the CBCT and the through the fiducial markers, everything has to be synced to the software so that the system can navigate that yes, this is the tooth and this is the patient, which is the concerned one. Okay, and through cameras, as you can see, there are cameras on the patient's head and through on the system where you can actually do dive into your procedure. Okay, so I want to show you one small video on it, and then uh, coming to all those things. Just a second. Okay. Uh, uh, so this is the video. Okay, so as I said, there is a CBCT scan. Over here, the CBCT is taken of a model. Okay. CBCT scan is done. Then the planning, everything is mapped that this is the CBCT of the patient. We are planning it. We are taking into action that how much we have to drill, exactly where we have to drill. This I will tell you the principles later. Just understand the concept of dynamic navigation first. Okay, so we are mapping everything on the CBCT. Okay, so over here we have to take a 14 axis. As you can see, we are planning. Now, as I said, fiducial markers have to be placed on the patient teeth as well as on the patient. So this is the placing of the fiducial markers. Okay. Now, this is the patient's registration. As you can see, patient's tooth is now being, you can see the motion. You can see the motion of the dentist. The dentist is using his, using the software, or you can using the system to give the access points. He is navigating all the points, be it the buccal surface, the palatal surface, all the cusp, so that to give a reading to the system that this is the tooth in question which I have to navigate. So he is going into motions from. Similarly, what we do on the intraoral scans, he is going from buccal to palatal to the occlusal surfaces and incisal surfaces, as you can see over here. No, and now we are checking the accuracy on the system, on the software, that exactly what we have calibrated is actually shown on the system or not. So you can see that whatever he has marked, all the palatal occlusal surfaces, all are recorded. Now, the preparation of for the surgery, or you can say. Now, over here, one important step is that. Hello. Okay. Sorry, I was stuck. Okay, now one of the important surgical step is that you have to also calibrate your instruments also. We said that CBCT we have given to the system. Through the fiducial markers, patient is registered. Through the calibrations, your teeth has been given to the software. Now you have to also calibrate your instrument. The system should know that which instrument you are using. Over here, we are using a rotor with the drilling bar. So you have to register that instrument also over here. So the surgeon over here, the doctor over here is registering the instrument also. As you can see, it's registering the drilling bar also over here. As you can see. And now he has started preparing. As you can see now over here, there is a target of bull's eye lesion. This is where your guided surgery, the one you have pre-planned on the CBCT, now this is your access. So a little bit deviation over here will give you an alarm. As you can see over here, as the doctor is, um, drilling, the real time mapping is shown on the software and on the system. This is the doctor's burr, and this is the pre-planned trajectory, and this is the bull's eye, you can say the bull's eye target where you have to follow, and any deviation from the path will alarm you. As you can see. Sorry. Okay, and then everything to be removed. Okay. Sorry. Okay. I hope this is clear. Okay. Just let me know if you want me to go through it again. Please tell me in the comments if you want, if you have any doubt over here in the dynamic navigation. Then we will further carry on with further with the pros and cons and indications and contraindications of it. So in the comments, okay, can you show the video again? Yes, sure, I will. Any other doubts which you want to clarify it first, so that then I can go again with the video. Any other doubt in the comments except the video? Okay, no problem. So I will start with the video again. Okay. So CBCT acquisition, planning on the CBCT, fiducial markers, registering the patient's tooth. Now, patient registration, seeing all the buccal, palatal, incisal, occlusal surfaces of the teeth are being marked. Now, to check that on the software, that whatever we have marked is correct or not. Preparation for the RCT and the instrument, as I said, instrument registration and starting of the drilling and removal of everything. Okay. Any other doubt? Should we go ahead? Everybody is okay? Like, clear with till here? Okay. I hope this is a yes. Okay, so going forward. Okay, so as I said, the concepts, CBCT planning, calibration, patient registration, accuracy and verification, instrument calibration, and then final guide drilling. Okay. So now, what are the advantages? You are, as I guess you will have known by now, you will get the real time, procedural, what is happening in a real time, and you can also change the path also. So the plus 1 point for it, then improve visibility, so you will know that exactly where your burr is going. Uh, so instead of using loops and all, magnifications also 10 times magnification, still you won't be knowing that exactly where you are going. So this will give you a pre-planned approach, a pre-planned, a larger map, that over here, yes, I'm going over here and have to reach there, and still I'm here. So you will also know the time that to reach over here, I will take almost 15 minutes or 10 to 15 minutes max. So yeah, so real timing and real path also. So useful in limited mouth opening cases also. This will, this line, you will come to know when we will discuss static, that why limited mouth opening is one of the most important thing, because sometimes I guess you will all be facing issues in upper seven, and that too if there's a distal caries, what headache will be for your files to insert also. So in such cases also they are helpful. Okay. So yes, improve visibility, no 3D templates and guides and all. Okay, so now what are the limitations? So, a higher cost, as I said, uh, now operator hand stability, as I said, you have to go through that exact bull's eye mark only. So your hand has to be a very, very good control over your hand. I guess you all are trained, more trained in doing activities than me. So you will have a very stable hand. But yes, so you had to have a very stable hand. It's very little technique sensitive, and it's very very higher cost. So basically, there are companies, uh, like a few companies which are supplying this. One of the most common in India basically is Naviden, and I guess in foreign also, Naviden is one of the most good company to supply this. And I was very very lucky to see this, to observe this, to learn this from my mentor, Dr. Neeraj Kinariwala. He's a pioneer in our India, and basically in Gujarat. He have this machine since last, I guess, 7 8 years, and he's good, performing it many surgeries. I also implant also on the system. So the cost system is very the machine itself is very costly, and every case you have to pay certain credits, purchase credit for every case. So again, it's not a one time investment, but it's a continuous investment. So yes, that is how it's expensive, as I said. So yes, as I said, ex- uh, expensive, and you have to have a very good control over your hand, and you have to be have a very good learning capacity. So all this we are learning, like before starting static, I just wanted to tell you one thing, that this is not this is not for the noobs, or you can say this is not for the people who have just passed out. No, because this is all helpful when you have a good, tactile sensations, when you are very thorough with your RCTs, when you are very thorough with your you know mapping of the canals, that this is where your canal will be, or this is where the apical ending will be, with the tactile sensations and all. So this is a adjuvant. Both static and dynamic are an adjuvant approaches, and are not the only solutions. So before so I will highly, highly discourage you from using it if you are a new passed out interns. Are any interns or recent passed out? Raise your hands in the comments, so I will know that. So learn this, remember this, and when you are good at it, when you have reached that benchmark, use this. So yes, so this is an adjuvant and not the only solution. Okay, so uh, starting with completing dynamic over here, and starting with the yeah, many interns are passed out, are raising hands. Please be thorough with your RCTs first, and then use this, learn this. Information is always key for your growth, but do not use this. Okay, as of now. Okay, now. Okay. Now starting with the static. Okay. Any doubt till over here? Please let me know any doubt for dynamic navigation or anything. Before we are, then we
अब्बा
are moving forward
क्या
to the.
मैं आया सुबह ही वो कर गया भाभी
Yeah,
घर
yeah,
में
please.
नहीं
Yeah.
बच्चे की स्कूल है ना जी नहीं मेन है बाकी भर्ती भी है और मेरा वो डीएल बनाने का है कार का वो
So,
बना को नहीं बना होंडा नहीं है वहाँ का है लेकिन वो नहीं होता ठीक है अबे बड़ा
uh, can please mute? Yes.
मैं घर में जाके बोलूँ
Can somebody mute? Okay. Okay. So I guess no questions till now. Okay. So moving forward to the static one. Okay, so as I said, going for static or for dynamic, one of the most important aspect is to know your CBCT thoroughly, very, very thoroughly. Okay. So as I was starting, I will tell you my one small experience. I know we have a limited time, but I want to share this. So when I was opting for my oral medicine and radiology subject, and when I passed out, I was still in the gray area, that who's going to use CBCT, like other than implantologist, or other than for the third molar. And I was right. I was very like very lost that I tried to negotiate with the endodontist and with the clinicians that please go for CBCTs also. They are not for the rare cases. They are not for those radicular cyst, like cystic or periapical regions, or type of cases only where you have to go for the CBCT. CBCT is one of the routine steps you have to take it, because you will be surprised that more than I guess 60 to 70 cases of upper first molars have MB2, and you will never know, because that is why CBCT is there. Without going for CBCTs, you will never know that most of your RCTs you are doing it perfectly, but the failure causes that you have missed those MB2 canals. So I was very, very lost. But now coming ages now, because of the new emerging clinicians and budding clinicians like you, I'm very thankful that now more cases I'm finding of CBCT for RCTs and for root canals, for finding those MB2s for lost canals, rather than like implants and third molars. But the cases are now coming, and I'm very, very helpful, thankful, and hopeful that you all go with it more and more. So yes, you have to learn CBCT for it. You have to know that exactly which sections to ask, which slides to see. See, we will give you everything, but then it's on you also that you have to learn that exactly what I have to see, what my radiologist is giving me. Is it right? Is it wrong? Is they delivering what I've asked for? So that is why knowledge of CBCT is very important. Okay, so diving deep, you can see the perforations. As you can see, a little small perforation reducent line on the. Oh, people are telling, please take webinar on CVCT. Yeah, sure, I am planning, but let's see in the future. Sure. Okay. So taking, as you can see, the most important sections to look for on CBCT is the axial and sagittal sections. Axial sections will give you the knowledge of your canals. Now, please note it. Axial sections will give you the knowledge of your canals, exactly how many canals are there, where your canals are located, and sagittal sections, or you can say, sometimes coronal sections also will tell you that is your canal through and through, is you can you track your canal through and through, or is there any perforation or calcification in between. As you can see over here in one of the cases, if let me do a slideshow first. Okay. As you can see in one of the cases over here, there is a little break. So this will help you that, see, my canal, you are doing your RCT and suddenly you will stuck over there. You will try to push and push, that why is not going further, why is it not going, and you will break your instrument over there. So this is where, if you have gone for a pre-op CVCT, you will know that this is where I have to stop. This much I have to stop, and I have to renegotiate it, or I have to call the patient in another sitting. So this is where one of the important cases where CBCT has come into an action. Actually, as you can see, that is my canal are located or not, or how many canals are there. Okay. So yeah, one of the few cases. Now, as you can see, the fracture lines also, where you can acknowledge uh, uh, where exactly your fracture lines are there. Okay. So even canal mapping, as I said, that where exactly your canals are located, as you have seen over here. Okay. So if you want to locate an extra canal, is there both merging where? In the middle one third, or in the apical one third, exactly where they are merging, and what is the canal track? Is my canal tracked throughout? As you can see over here in one of the cases, both MB and ML are merging, but they are merging where? In one of the cases, they are not merging; they are going straight. So you can check that. As you can see, I've tracked the one canal over here, which was very narrow, partially calcified. So, but with the help of CBCT, I helped them to track so that they can negotiate in the further sessions. Okay. Even the lateral canals. One I was very happy to locate one of the lateral canals also. Sometimes nowadays infections are also very smart. They are filling everything, and yet lesion is there. Why? Because you missed the lateral canal. So sealing, you have to seal it properly. Instrument negotiations. Sorry. Uh, Instrument, you can negotiate your instruments, everything. Even one of the cases, I guess you will all, you might all have been seeing it. As I said, lower anteriors are very common to variations. So you can see this was a scenario. There was a huge, you can see a periapical lesions, periodontal case, periodontal abscesses were there. So the doctor actually have sent that for the location for the bone density and to see that this tooth are salvageable or not. And to the utter shock that all the teeth, as you can see, 4142, 3132, all have so different variations. Lower anteriors, they all were having different variations, and you will be surprised that if we'll have tried to negotiate it, I don't know what will have happened, because as you can see, they have all different anatomies. Okay, so this is one of the cases where you can use this guides. So coming back, as I said, use of CBCT. CBCT is one of the most important factor. You have to start with first CBCT. Okay. Now, selection criteria. So, as a static guide is useful, easily accessible, but it also has certain limitations. It is not used in all the cases. As I said, there's a very large pool of, you know, a large pool of research still needs to be done. So, what are the ideal cases and where you can use it? Now, starting it. So, they are used where they have the straight access. You have to have the straight access. So now you will see, now you will question me, like, then we can't use it in the dial serrated cases. Yes, dear, you cannot. See, you can negotiate dial serrated cases up to only middle third, I guess, because usually apical one third or apical end are dial serrated. So up to middle one third, you can negotiate them because it has a straight line axis. Once you can get the path, then you can try to negotiate it through your normal files. Okay, so it has to have straight line axis. So the basic, most commonly used teeth are anterior teeth. So and see, upper anteriors, one of the very easily accessible because they have a straight line axis only. So as I said, ideal cases are anterior teeth, straight line axes, and severe calcification with visible apical lumen. So there was a case that there was a breakage in the middle. So, but we can locate that on. Actually, we can locate. Ke, haan, chalo, there is a lumen over here in the axial section, and in middle somewhere there might be a calcification. So such cases are the ideal cases, which are less ideal, exactly curved canals and posteriorly. Now we have discussed before there's a limitation that the dynamic navigation can be used easily in less mouth opening teeth, or like if you have a less mouth opening and you can still use it. This is static is one where it is limited. You cannot use this in the patients with OSMF or on the upper seven, you cannot use it. Even sometimes in the lower seven also you cannot use them if patient have a severe OSMF stage 2, stage 3, where mouth opening is severely limited. So, or TMJ problems, where again the mouth opening is limited. So yes, you cannot use static in such cases. Okay. So why? Again, coming. So first, digital workflow, CBCT, most used have to be there. Over here, one again is intraoral scan. So instead of markers and registration, which was the workflow in dynamic, over here the workflow is CBCT and intraoral scan of the teeth. So no impression. You should have to have intraoral scanning because it will give you again. I don't want to go into the debate between manual and this digital scanning. Intraoral scanning is required over here. Okay, so now how it is done. So you will have the CBCT data of the patient and you will have the intraoral scan. Okay, Now, using this too, we will merge them. So, intraoral scan will give you an idea about the soft tissue analysis, the emergence profile and everything, your gum tissues and all. And the CBCT will give you the heart tissue, answers for the heart tissue. Merging them both will give you your complete whole data set. Okay. Now, we will use this to navigate our canal. Now over here, you will also now again will have a question that, as you said, if the canal is calcified, then how will you use to guide it? So there's a law for it. I guess many endodontics over here will know the law of centralization. So what is the law of centralization? That it is said that the pulp canals are usually always in the center of a tooth on the CEJ. The canal opening is usually in the center and at the level of CEJ. So, using that knowledge of centralization, we will try to assume. This is just for the cases where in the axial also you cannot, no, you cannot able to find the lumen. So let me show you the cases. Uh, I'm talking about the cases where, see over here, as you can see, the central you can find the lumen, and the canine you can the radiolucent dot in between. You are able to navigate the or negotiate the lumen, but in the lateral incisors you can see there is a no radiolucent signal. That means no lumen is found. So what will you do in such cases? We will use the law of centralization. As you can see over here, I am using the law of centralization and trying to negotiate virtually that of course the opening will be from the palatal now about the cingulum, and I'm thinking that it will go in the straight line. So using that knowledge, I'm trying to use the applying those knowledge over here. Okay. Okay. So we will negotiate it, and we will this is one of the softwares which I'm using. There are multiple softwares you can use, one such as Blue Sky. There's a Core Diagnostics, DDS Pro, also 3Shape, Exocad. All softwares are good. You if you are thorough with any of the software, you can use it. This all softwares are similar to what you are using in implant planning. So any software which you have for the implant planning can be used for the digital endodontics also. Okay. So this is one of this is I'm using Blue Sky Bio. So this is one of the case from my PG days, by Dr. Krishna. I'm from Ahmedabad Dental College, from Ahmedabad, Gujarat. So this is the case from there. As you can see, I have navigate the canal. I've located the canal by the law of centralization, and I have virtually placed my or decided my path. Okay. Now, by using the knowledge of path and all, I will have my exact like length, that how much I have to drill to reach the apical, and how much I have, what size of burr, or what size of drilling machine I have to use. Aerotor I will use, but the drill size, you have to be very precise about the drill size also. So what type of drill I will be using, how much length will I be going inside, like by drilling, everything will be decided. So burr diameter, my drill angulation also, that at what angle exactly I will be going inside. This is all pre-deciding factors. So I will decide, I will plan everything virtually, and a template will be found. Okay. So for burr, the as I said about the burrs. So most commonly used burrs for endo guides are SS White. What we are using it over here, they are easily available. So SS White have a particular no, they are carbide burrs or no diamond burrs. So carbide burrs, they are long shank burrs, because you have to go through and through the burr. So over here, you are not using any files. You are completely negotiating your tooth through the drill only. So you should have a long drill burrs. First of all, that's one of the most important criteria, and SS White is providing you with that. Okay. As you can see over here, the burr. I am using it through and through till the apical line. If I am getting a straight line access, if I'm not getting a straight line access, if I'm getting it straight line access till middle third also, I'm using the burr till middle one third, and then rest I will negotiate it through the, you know, you can say through the files. Okay, so the drills should be very well stabilized. It should have a good cutting, capability, because it have to cut the dentin also. So cutting, angulation, stability, and most important, long drilling, and of course the drill diameter. They have to be very very slick. Point, you can see over here, 0.81, 1.2, 1.5 mm. That's all. That's the burr diameters, what burr diameters are. So they have to have the slick diameters, long shanks, stabilities, and a good sharp, or good cutting ability. So carbide burrs are very well used in this, and not the diamond burrs. Okay, so taking all these aspects into mind, everything, I will now print my guide. So print my template. So this is a video of how a guide is printed. So this is one. So this is all 3D printed. So after planning everything, I will give the command for 3D printing. This is the machine I'm using to 3D print. They are the acrylic, you can say same like your resins which you use in dentures, but of different quality. But they are the resins only. So they are 3D printing resins. So I'm using them to print. Then this is the platform. This is the platform where I have printed them. I'm removing them from the platform. Sorry. This is how I'm removing it. Then comes the processing part, where in the isopropyl alcohol, I will, wash them, wash any remaining resins on top of it. So I will wash them in the isopropyl alcohol for certain minutes, and then I will cure them. Okay, this is my curing unit. This is a UV light where I am curing them. Okay, and the final product I will get is a 3D printed guide. Okay, similarly over here. Okay, so this is a 3D printed template which will sit on top of the occlusal surface of your teeth, and will have a slick hole. As you can see, this is a guide hole, and on top of it is there is a guide hole. This is a guide tube, sorry, and on the top of it there is a guide hole from where you will insert your drill. Through the erotor, you will insert your drill directly into the pre-planned position which we have already planned. Okay, pre-planned trajectory, you can say. You will directly drill into it. Okay. I hope I'm clear. So, is there any doubt? We will then further go for the principles, pros and cons. But I guess the mechanism, the working principle, everything, I think I'm clear. Any doubt till here? Let me know so that we can go back. As I said, CBCT, intraoral scanning, both to merge, we have to plan, then we have to design the guide, then we have to print it, and then there's a clinical. We'll come to the exact steps of the surgery, but mechanism, I hope I'm clear with the mechanism. Any doubt till now? Let me know in the comments. Okay, I think everybody's clear. Do let me know if there's a doubt, if the doubt is silly, because this is a very, very advanced topic. How silly it might be, do ask. Okay. Okay. So most important overall principle, as I said, uh, it's not an autopilot. You should have the knowledge of your tactile sensations. You know everything you should know beforehand, uh, before going for this guided approach. So you can see the precision of guided endodontics is determined less by the guide itself and more by cumulative control of planning parameters. So, sorry, somebody's writing, burr is drilled in cast or what? There is a guide hole above it. I will let me show you one. Just a second. it is the file is not supported in this. That is how I cannot. Let me show you. Okay. So there is a hole on the guide itself where predetermined hole, and you have to directly insert it. So you don't have to drill through the guide, like you don't have to drill into the guide. There is already a hole where you will use that. Okay. Just a second. My internet is lagging a little bit. Sorry, these are my cases. Just a second. Sorry. Okay. I will show you in a while. After ending this session, remind me to show you the exact template because it's not supported over here. So I cannot show you the exact template of my case. But remind me and I will show you. Okay. So yes, as I said, you have to have the no pre. You don't need to prepare excess cavity. You have to. You have to. This is the excess cavity, ma'am. We require to place the template over the dentation of the patient and drill through with the. Yes, as I said. See, let me show you once again. See, as you can see over here, is that there is a teeth, and on the top of the teeth, the template is placed. So the template is placed on the teeth. It is adjusted on top of the teeth, and then you have to drill through it. Okay. There's a hole. As you can see, there's a hole over here, and this drill is there, and through the drill directly the tooth is below it, and there's a predefined path. So through the drill only directly you will access into your cavity. uh, the question was, do we still need to prepare the excess cavity till the roof? Wait, this will come later in the whole workflow. This is just the workflow of the guide preparation. This is not the workflow how you will start your RCT journey. So I will come to that. Okay, wait with me. Okay. So as I was saying that this is an adjuvant, and in this also the end result will be as beautiful as the planning will be. The CBCT, the planning, the preparation of the guide, planning and designing of the guide, all parameters are more crucial to have the end result beautiful. So, and it's a both effort of the surgeon, the endodontist or the clinician, and the uh, you can say the reader or the designer who is I'm planning. So the combined efforts of me and the clinician who is going to place it. So by the efforts of both, this is going to happen. Okay, so it's a both combined role of a radiologist as well as a clinician. Okay, so scanning is done and then the implant is sent by the lab. Yes, dear. So this template. So scan. So you have to wait. I will tell you. So there are questions that how will you do? Okay. So coming to the workflow of the guide itself. So you will, from the clinician's point, we just require two things: a CBCT of the scan of the patient, I mean, and the intraoral scan. So taking this both, you will send them to me or the lab or whatever, who's ever is going to design your guides, and then they will contact you. So usually in my case, if I'm telling you, I can contact the doctor that doctor, this is what I have planned. Is it correct? Because at the end, you are the one who's going to drill it. So I will tell you. Then together we will look at it, look at the picture. Is it properly planned or not? And then, if all is done correctly, I will design, I will print it, and then I will deliver it to you. And you will continue with your surgery. Okay. The steps of surgeries, what you will have to do, will come later in this lecture. Okay. I hope till over here everybody is clear. Okay. So, what you have to provide, like you have, like the clinician have to provide, and where is it exactly placed? It is placed on top of it. So they do they tell number of canals? Yes, everything, dear, everything. Once it's same like you are getting a report. It will tell you number of canals everything. But you have to tell that, so there are two canals, but I have a problem in this canal. So I will, because one guide will have just one hole, which is predefined for that trajectory only. So for two holes, if there are, if you have a doubt in palatal, or if you have a doubt in MB2 also, that there will be a two, you have to be have a two guides, or a two guide hole made on a single guide, because one will have, the one guide hole will have a predefined trajectory. So if I am preparing it for MB2, you cannot use that on another tooth, or you cannot use that for another canal. It is pre-designed or predefined for that particular MB2 only. So if you have two canals in questions, one guide will have two holes for that. One is for the MB2 and one is for example, if palatal, that palatal. Somebody asks for grossic areas. Yes, you can use it on grossic areas until and unless your tooth is, you know, can hold the guide above it. If you have a proper, see, grossic areas have almost more than two, three walls destroyed. So if the remaining walls are strong enough to sustain the guide, then yes dear, you can, or you can do a little bit of, conservative removal of it, or you can prepare a composite walls through it, and then you can also place on top of it. So as what you do, usually you can build a composite walls on top, through it, and then you can place the guide, and then yes, you can have the trajectory. It is one of the actually useful in grocery areas, as everything has been destroyed. You won't be even also able to look for the dentinal mapisthemus also. So with the fear of perforations, actually you can use in grocery areas, but you have to prepare a wall to sustain it. Somebody asked for curve canals. No, dear, as I said earlier, you cannot use this in curve canals. It has to have state line access, and that's what it is. And coming to limited mouth opening, as you can see over here, this is sitting on top of the tooth. So you should at least have a minimal mouth opening, where you have to consider first the tooth, then on top of it, almost you can see the thickness of it. It's around 15 to 20 mm thickness will be there. So you have to have a 15 to 20 thickness on top of it, and then there will be a long shank burr. Long shank will be of around 15 to 18 Itna, there will be a huge length. Then you have to use that to drill from top. So you should at least have 40 of mouth opening, basically 35 to 40 for the posterior teeth. If it is for the anterior teeth, you can easily do it, because that does not needs anything for the mouth opening. So yeah, limited mouth opening. The dynamic is better than static, because static cannot fit, and no curved canals. Yes. Any other? I guess I've cleared all the doubts. Anything else? Okay. So coming back to the many institute of private sector for okay. CBCD courses will take that in hand. If you have doubts for this, just let me know over here. CBCDs will come in the end. Okay. So as I said, SS White Endoguide was what we are using it. But in posterior static is not ideal. So you told if it's only for anterior. Yeah, as I said, if you have a good mouth opening for six for premolars, where you are having variations, mostly in 4 and 5, upper and lower, where you don't have where you have two canals. Uh, but both canals are merging. I'm sorry. Am I audible? So sorry, my I guess. Am I audible? Am I visible to you guys?
You are visible and audible.
Okay. So, where in the cases of premolars and canines, also in first molars, also where you can have canals which are merging. Yes, you can use them in such cases. Somebody asked me if the cost has increased or not. See, cost as in this comes around 4, 5, 6,000 max, less than 6,000. honestly. But if you are going to educate, if you will educate your patient likewise, that see, this will help. This all comes to, good education, tactic skills. You have to tell your patient that, see, this is very calcified. We have to salvage your tooth also. We have to, save the tooth. We're trying our best to save your tooth, because the cost of replacing the tooth is much, much more than, saving it. So if all those things are coming together, then yes, I don't think so. Patient will not. As I said, see, now the shift is already coming. Patient are ready to pay for the CBCTs also. So it's all about, how willing the patient is to save his or her teeth. This all comes down to that. So you have to tell them that, as I said, the cost of replacing it is much more. The implant cost to 25, 30, 35, 40 Ks. So replacing it is much more expensive than salvaging it. So if the and this is in thousands, less than 5,000, this is going to cost you. So if under 5K you can save your tooth, then what is the best deal you can get? You are saving 40s and 45 Ks of yours. So this is how you communicate CBCT and guides for endo for us. So for us, so you have to ask your local labs, and you can contact me after the session. We'll discuss. Okay. So basically, I hope I'm clear. This is all how you explain, and how
Ma'am,
the patient,
you said
how your patient.
5K is cost for the doctor or for the patient?
Sorry?
5K is
Hello? Huh.
cost for the patient or for the doctor?
See, it depends from city to city, that what is the cost going around your city. So in my city, the CBCT cost 1,800 for a sectional tooth. I don't know what's there in your area, or what's there in your area. The cost of CBCT is, and then the making of the template. 5K, under 5K is, what the you know you can say the one who is going to make it is taking it, or we can come to an agreement. Like, as I said, this is all, for the after the session. uh Basically, the patient have to spend a little, not much, but have to spend a little, 5 to 6 days. So yes, you have to talk with your local labs also, that what they are providing, what is the printing cost for them, and which softwares they are using. So very honestly and openly ask telling that as I said, each software has its cost. Every printing has its cost. So based on those protocols, you can come to a conclusion. But CBCT is one of the thing which is non-negotiable, and has to be, you have to contact that with your local uh, center, that what is going to cost me. As I said, we have 1,800 to 2,000 in our area. So you have to look for that, what is the price in your area. But as I said, what is the willingness of the patient, and what is willingness of yours also to salvage it or to extract it. So based on that, you can take this step, as I said. Okay. Any more questions? I have some questions over here. Just a second. Cost of CBCT, what will be the charges? Same over here. Okay. So okay. I guess all questions are done. Coming back to the birds. As I said, SS white endogyte birds are there, and molars birds are also one of the beautiful birds. But molars are, I guess, a little bit expensive. SS white endogyte birds are easily accessible and easily available. So yes, you can use that. Okay. Clinical application and guidelines. As I said, they this now, okay, let me show you the birds. So these are Muller's longshank. They are, they have a circular or round tips, and they have the pointed words. So I use the SS Endo guide. I advise the clinicians to use SS Endo guide, because they are more, conical and more straightforward, rather than the, circular ones. Okay, they tend to form the ditch and ledge. So for me, SS Endo white Endo guide birds work well and fine. Okay. So okay, we are. As you can see over here, the holes are there on top of it, and this is the template which sits on the teeth. So if you have two areas to cover, you will have two holes. Okay. Now coming to your aspect. So now what will be your steps to cover this? Okay. So starting with, you have given the appointment to the patient. This will take almost 1 to 2 days in total, from planning to making of a guide template. Maximum 3 days if you are living far and you have a lab far away, so to reach. So maximum 3 days between first and second appointment. So you have to give a minimum period of 3 days to the patient, that this is what we are doing, and your guide will reach to me within 2 to 3 days. So second appointment has come. You have the template ready. Now what will you do? Now starting of the armament area. So first, okay, just a second. I have the whole. Okay, so first, starting of the guide is, you will place the use of rubber dam, non-negotiable. You have to use the rubber dam. Matlab, if I think all are using it rubber dam, I'm assuming all of you are using rubber dams for your RCTs. You have to use it. So rubber damming, prepping your patient with this. Then you have to place the guide over it, and you have to start initial. You have to check that is it properly sitting or not, is it not wobbling, you can clearly see your tooth, everything checked. Remove your guide and start with the excess preparation. See, if you have not done the excess preparation beforehand, if the tooth is new, and you have done a very pre-operative CBCT before even touching the tooth, this is for them. You have to start with the initial cavity preparation. You have to de-roof it, and you have to come till the CEJ, where you can clearly see the dentinal, or you can see the pulp canal mapping, where you can see, or where you can locate not the tooth, not the canal in question, but the rest of the canals. You have to de-roof it completely. Okay, and if you have already de-roofed it, you have to remove if you have placed a temporary restoration, you have placed a cotton, whatever you have placed, you have to de-roof everything. And then after de-roofing it, after completely clearing all the walls, if there is a case of gross leak areas, you have to prepare the walls. Everything done, then place the guide on top of it. Okay, after placing the guide, then you have to use the SS endo guide burrs. SS endo guide burrs are cavity preparation burrs. Sorry, I mean the drilling preparation burrs, and not the de-roofing burrs. You don't have to use this burrs for de-roofing. Okay, so normally as you are doing the irrigation and all, everything you have done, placement of the guide, as you can see in the number 1 step, then using the guide drilling, no guys, SS white endo guide burrs in this, and then you will use to drill it as the trajectory is there. You will start drilling it in between to remove the dentine, to remove the debris. You will use the hypochlorite solution, what we are doing in the initial BMP, basically BMP, but instead of files, you will use the guide, burrs. Similarly, you will start negotiating through the, by solution and through the drill, and you will reach your destination. If there is a case of we are drilling it up to the middle 1/3 only, so you will drill up to middle 1/3, then you will remove the guide, you will remove everything, and you can, now you have a good opening, you have good access, and now you can continue with normal your file only. You can use your file, you can start using your file, and you can continue with the rest of the RCT as you are doing it. I hope the workflow is clear. No de-roofing has to be done beforehand, before placing the guide on top of the patient. Okay, so everything has to be done beforehand, then the guide, then canal negotiation, in between, using of hypochlorite solution to remove the excess debris and all, and then the final preparation, how you are sealing and how you are obturating it. Okay, I hope I'm clear with this. Okay. So as I said, the pros and cons. beforehand it was operator dependent. You have to lost so much of your pericervical dentine. You have to, do a lot of, removal of the dentine, and perforations was there, access exact point where you are drilling it. So yeah, the conservative of the dentine also. Now coming to the literature says had freehand, the literature comparison between freehand, dynamic and static. Of course, freehand loses, and dynamic and static comes to a, similar, almost similar questions. As you can see, for the root canal localization, both have similar success. Dendron preservation is slightly highest in dynamic because are having a real time imagination. You are having a real time focus. Operator dependency, of course, static does not have the operator dependency. It is all prefabricated, pre-planned for you. But in dynamic navigation, you are the one who is going to plan. You are the one who is going to use. Yes, I forgot to say that dynamic navigation is all you. That is how it has a steep learning curve. It is all you. You have to plan it. You have to use a machine. You have to do all those fiducial markers and registration and calibration. And then you have to start with the drilling process. It is all you. So that is how it is more operator dependent, and the static is less operator dependent. Okay, because it is given to you all pre-planned. So as you can see, and risk of perforation, it is of course next to zero, you can say, because you are getting a real-time solution. But in static, no, if your guide is not sitting properly, if you have not checked that is it sitting properly or not, no, there are factors which can affect, or this is one of the, or your planning is not right. The planning was all faulty from the beginning was only. Then you can have a major blunder. Okay. So again, dentin preservations also, as you can say, dynamic have the highest. Static is also having high real-time tracking. Need for printed guide is not there in dynamic, which is there in the static cases. And best clinical indications, as you can see, dynamic can be used in mouth. It does not care for mouth opening. It does not care whether you have a good curved canals or not, because it's the you who are doing it. If you are going to calibrate the aerotor, okay. If you're going to calibrate your files also, then you can get a real-time mapping of your files also where it is going. You have to calibrate, but just you have to calibrate your whatever instrument you are using. You are using a, aerotor, calibrate it. If you are using your scaler, calibrate it. If you are using a file, calibrate it. Everything needs to be given to the system, needs to be fitted to the system, and you can use it. Okay. Where static only, and the mouth opening has to be good, no curved canals, and a little limitations are there. Okay. So as I said, cost, the major question for all of you, cost is there, CBCT. A little bit of radiation exposure, because CBCT is must needed, and static is little bit less flexibility, because you will have what it is there, will be given to you, then you cannot differ from there. So a little less flexible, and there's always a learning curve. Okay, in this future, as I said, lots of hope in this, uh, for all of you. I hope you can all come with a new and newer, newer type of machines and bursts for this. Now, coming to an end for this session, a little clinical pulse, a good FOV CBCT with a good image clarification, high definition, very, very stable sitting guide. Maintenance of the irrigation, I said, you have to continuously go with the BMP. Prefer anterior cases. Start with the ideal cases, and you're cross-checking your trajectory. So in between also you have to take the IOPAs. The role of IOPA is never going to outdate any guided systems or any digitizations. IOPA is going to be there. So in between cases, it's better for your first few cases, that you start, take IOPAs for that you are going it properly. And when you have developed confidence, you can go without IOPA also. So I hope my references, and these are my contact details, my LinkedIn and my Instagram. I'm from the name Grayscale. So do follow me, and I'm open for questions. Let me know your questions. I'm ready to help. Yes. Any questions? Shoot up. Okay. Hope this was a meaningful seminar and you learned something from this. Thank you. Any questions? I'm ready to take questions. One have written, do metallic restorations affect guide planning? Yes. Artifacts are one of the most problematic thing. I talk on that because artifacts creates radiolucencies. So metal artifacts creates strict artifacts which are known as strict artifacts. They are radiolucent subjects, so they will hinder us for the proper canal localization. So it's better that if you are planning it thoroughly, go for the removal of crown or composite, whatever is there. So it will help us to locate the canal more properly. Okay, so yes, metallic restorations may hinder it. You have to remove it beforehand. Ma'am, we have to de-roof first, then use this guided template. Yes, dear. As I said earlier, if you are planning initially from the starting, you have to de-roof it with your normal cavity preparation burrs. And then you have to place the guide and then you have to start drilling. Course has to be done to learn all lab guy can scan. Intraoral scanning, I guess your lab guy can do it, and you can also do it. First, you can start with, using it on the models, and then you can start with the patient. Intraoral scans are, they don't have any radiations. Use it, try it on your patients also. There's no harm in doing anything. You have to experiment it. You have to be very thorough with your intraoral scans. And yeah, I guess intraorals can, it's up to you. If you have a contact with the lab guy, you can ask them to come or you can do it on your own. Okay. So any other
Thank you,
questions?
ma'am. My turn.
From ma'am,
FOV and radiation dose for CBCT in endo mode. Yeah, that's a very, very
madam,
important question. So FOV.
so
FOV has to, sorry?
madam, one doubt. From roof to floor, that will be a free
Sorry?
area. From the roof of the pulp chamber to the floor of the pulp chamber,
Huh?
how will it be guided?
The
That's an
guide
empty
will
area.
be from the roof to the apex. I think you are asking that, right? I'm not getting your question.
If this is a big pulp chamber, as in young
Hmm.
teeth, the from where this guide start, from the orifice or from the roof?
From the,
How will
it's
you
depend
locate the
upon
orifice?
you.
It
As
will
I
go.
said, you just have to de-roof it. You
See,
have to de-roof up to, because see, you are making guide why? Because you cannot locate the canal orifice. You cannot locate the opening. So you just have to de-roof it. That is the floor, up to the CEJ. Everything is removed, and then you have to place it, and the drill will only help you for the canal opening. If you are asking that, the drill and the guide will help you for the canal opening only. Okay,
orifice,
so you can,
canal orifice.
yes.
This will help to locate the orifice.
Yeah, the orifice only, because see, that is why you are making it now. Because see, you don't, for example, you have seen that there is an MB2 canal in the CBCT. I can see an MB2 canal in the CBCT. But when I'm trying to open, I've removed, I've started my I've started my RCT. Now finding it, I cannot locate the opening of the MB2 orifice. I know it is somewhere near it. My radiologists have told me that there is an MB2, but I cannot locate the opening only. I have removed all the dentine, I have removed everything. Now there is a problem for perforation also, but I cannot have the opening.
Okay.
For that canal opening orifice only, you are making a guide that based on the CBCT, the radiologist have provided you from the knowledge of that CBCT, a guide will be prepared. And a you can say a pre-RCT is done on that, because it will be planned in such a way that your burr will directly, point on that location only, and you will have a perfect opening. That is why I'm saying it in the upper molars or lower molars or seven also. If you have a good mouth opening, if you have a curved canals also from the middle one third or apical, but you just need the guide for the orifice opening only. So you can use this. You can use the guide. You can use this for the canal orifice. Remove the guide and continue. You have the canal opening. You have the canal orifice opening, and you can continue with the RCT as you are doing it. So this is just a template to help you locate that where exactly your canal is going to open. Hope I am clear.
Okay, ma'am.
Okay. Okay. So I got a question from Dr. Fasna that FOV and radiation dose. Sorry, doctor, I missed your question. So yes, one of the most important FOV, that is field of view. This is very, very important one, and you have to ask your CBCT center to give you in the as low FOV as possible, low as in small FOV as possible, which can be 5 by 5 or 5 by 4, the lowest which your center can provide you, because the lower the FOV, more will be the definition or more will be the clarity, where we can we can have a very clear view of the canal locations. So yes, radiation dose also will be lesser because you're not reducing the FOV. So of course, only that much area is going to get exposed rather than the whole. What the centers do, they take usually there are technicians over there. So they don't know that which tooth has to be selected because they don't know the 36 matlab kya 36 yeah 36 tooth number. So what they will do, they will take the whole. So they will give the radiations also more compared to the small FOV, and then they will cut that area, whatever the radiologist is going to say, and then they will provide it to you. So you will have to specifically ask that I want as low FOV as possible. Okay. So hope I'm clear, Dr. Fasna. Hope I'm clear. Yes. Any other questions? Okay. I hope I'm very clear. Okay, should we end this, or there are any questions? Do shoot. Okay, thank you, everyone. If anybody have any doubt or anything you want to approach, you can approach me through my LinkedIn profile or through my Instagram profiles, and do leave your reviews in the so that it helps me motivate. And surely I will come up with a CBCT course sooner for you guys. Okay, hope. Thank you. Dr. Juna, should I leave?
Hello.
Hi, yeah.
Hello, doctor. Yeah.
Yes,
Thank
hi.
you so much, doctor. Yeah, thank you so much. Such an outstanding and insightful presentation. We sincerely appreciate the time, effort, and expertise you have shared with us today. Thank you so much.
Thank you.
And yeah, on behalf of IIDPE, I extend our heartfelt gratitude to you accepting your invitation and making today's webinar such a memorable experience. A big thanks to all the doctors who joined us for this evening. Your enthusiasm for learning and active participation that make us see this a continuous success. We hope today's webinar has provided you with a practical knowledge that you can confidently implement in your clinical practice. Before we conclude, we encourage everyone to do follow Dr. Dhruvi Shah's ma'am's professional social media pages to stay updated with her excellent clinical work and educational content. Also, don't forget to stay connected with IATP for many more exciting webinars, workshops, and hands-on programs. You can visit our website www.iadp.org and follow us on Instagram and Facebook for regular updates. If you missed any of our previous webinars, they are available on our YouTube channel. Do subscribe and continue learning with us. Once again, thank you, ma'am. Thank you to every participant, and thank you, the team IADP, for making this event possible. Stay safe, keep learning, and keep growing. Have a wonderful evening and good night.
Thank you. Thank you for this platform. Thank you. Do follow us. Do follow IDP also, and do follow us. Thank you. Bye, guys.
Thank you. Bye.